So just a few housekeeping things really. Kate is recording this call because there are people who'd like to see this talk and can't do it at the moment. So just so you know, this will be recorded. As Kate said, this is a pilot event. We've done this in response to LNU and SCU teams saying actually we'd really like some education resources focused on us, as well as everything else that's quite relevant for all teams. There's a lot of us on the call today, so please, when you're not speaking, please keep yourselves muted, have your camera on or off. If you'd like to ask a question, please either type it into the chat or raise your hand, and I'll be grateful for my fellow speakers and for Kate's eye on the chat and the hands up, because I can't see that when I'm sharing my screen. And finally, at the end, if you're not already a member of BAPM, I cannot more highly recommend it. I have really enjoyed all of my involvement with BAPM. I've got to work with some wonderful, wonderful people, and to be able to get involved with big documents, big work alongside fantastic colleagues has just been a great privilege. And it's only through the membership contributions from those who join that we can continue to produce lots of resources like this. So please do join if you're not already a member. Okay, so without further ado, I will share my screen for you. And I'm hoping that you should now be able to see the first slide. Can someone say if they can or can't see it, please?
Okay, Sarah, thanks.
Thank you, Kate. Brilliant. So yes, in the next hour and a half, we'd like to talk a little bit about perinatal optimisation with a real focus on what does that look like for LNU and SCU teams, because so much about this sometimes is directed at NICU teams, but obviously these women who are in threatened preterm labour or needing preterm delivery don't always pitch up to NICU units. And of course there's a large volume of preterm babies that should and can be born in LNU and SCU units. So how do we give them the best pathway of care? So I'm going to go through initially just some of the changes that came with the new preterm framework. I say new, it's 2019. A lot's happened since 2019. But yeah, a little bit about that framework and what does that look like for LNU and SCU teams. And then I'm also then going to talk about how do we optimise the care for those babies, because that really does alter outcomes. And think about, well, why does that matter? Why do we need to do all this work to improve outcomes? Then I'm going to hand over to George. So it was a privilege working with George on several different things, but most recently the optimal cord management QI toolkit for BAPM. And George is fantastic. He runs one of the, I think, only ANNP led units in the country. And he's a fantastic speaker. It's just a privilege to have him here. After George will be Ros, who is a senior neonatal sister in my own unit in Swindon, but also an infant feeding specialist nurse. And Ros has been passionate about preterm optimisation and particularly about early maternal breast milk. And she's a fantastic speaker on this topic. And then we would like to hand over to all of you. What would you like to talk about? What are the issues that are facing you in your units and with your teams? What questions would you like to ask of the speakers? Okay. So if we first turn to the new framework for practice, which was released in October 2018, I've already mentioned about my role for BAPM. I hold the same LNU SCU role for the NHS England Clinical Reference Group for Specialist Commissioning. And within the South West Division, I'm the operational clinical lead for Preterm, which is a preterm optimisation project. And I will touch on some of the resources from that because they link in very much with the QI toolkits. There's my contact details. Please do feel free to get in touch about any of this. So let's think about the original preterm framework back in 2008. And that was published in response to the Nuffield Council of Bioethics document. And this completely oversimplifies the document, but roughly you will all remember that below 23 weeks we wouldn't have resuscitated, and actually for 23 to 24 weeks perhaps some of them, well, mainly would not. And 24 to 25 weeks, that was where the grey zone was, and above 25 weeks you would resuscitate. But you'll all be well aware as clinicians working in a perinatal environment that there were some issues. We've all seen that the outcome data and trends, they've been changing. There's been a global change in practice away from those thresholds, and also that it isn't gestational age dependent alone, and that increasingly we can see that family involvement in care and shared decision making is absolutely key. So let's look at the data then first. This is some of the changes. If we think back, the original Epicure studies, and we were privileged to have Neil Marlowe on the working group with us, were in 1995 and 2006. And so that's quite old data. And if you look at the 2016 Embrace UK data, you can see that really across all the gestational ages, then survival has been increasing, and perhaps most markedly for the 22-week population. And really to have a concept that at 22 weeks there's no chance of survival perhaps was no longer completely accurate. And I think I definitely can remember several times being bleeped in the middle of the night when, as a registrar, to come and counsel a lady who at midnight, who's just become 23 plus 0 weeks. And of course, it feels like such an arbitrary line. The physiology of that baby has not changed. It's not a Cinderella moment. It hasn't suddenly turned into a viable baby with an excellent chance of survival from not having any chance. It's not turned in from a pumpkin into a princess overnight. And there were many other factors that would matter. I often think when I'm called to go and see a very growth restricted 24-week twins with chorioamnionitis, that actually maybe things are really different for that than a well-grown healthy 23-weeker. So I felt like it couldn't just be gestational age based alone. And if we think about the ultrasounds, when I talk to the ultrasonographers where I work, I say, well, how accurate are you with that 12-week ultrasound? Because we're basing an awful lot of big decisions on that. And they say, well, on a good day, it's plus or minus 3 to 4 days, maybe more, maybe less. And that again creates issues where you have set lines in the sand based on just gestation alone. So many of you will be aware that the new framework really talks about individualised risk assessment for every single situation. And yes, gestational age does matter, of course it does. And most of those 22-weekers will still be in the extremely high risk category. And I think it's important that we bust one of the commonly held myths about the new framework. We certainly were inundated with emails asking us about the framework for resuscitation of 22-weekers. The framework does not say to resuscitate every 22-weeker. It says to put every baby through this risk framework. And it might be different if they're towards the end of the week. It might be different if they're growth restricted. We know that male fetuses do differently in terms of outcomes after preterm birth. And we certainly know that multiple babies as part of a multiple pregnancy will do slightly worse than their comparable singleton pregnancies. But if we then think about, well, what can we change? And the second part of the talk will very much come onto this. Well, how do we change that risk of poor outcome? And for us as LNU and SCU teams, then we'll be seeing this lady and we need to think, well, if we had the chance to give her a complete course of antenatal steroids and move her to the correct setting for birth, so sub 27 weeks, we're talking about a hospital with a co-located NICU, could we change that outcome? So actually, does it move the risk category for this baby? And these are the sorts of conversations that we need to have. They're not easy conversations, and the framework very much insists that they cannot be done alone by a neonatal person. They have to be done as a perinatal conversation. Ideally, the most senior neonatal person around, the most senior obstetrician, and the midwife caring for that woman. Because I'm sure we've all been in situations where we've had mixed messages, mixed information, and we need to be consistent. There's lots of useful resources in the document for communication and top tips, useful phrases to try. And that's because if you, like me, work in an LNU or SCU setting, presumably you've joined this talk because you're the person in your unit with one of the people with a neonatal interest. But you might have many colleagues who are on call for the neonatal unit who might not have as wide a neonatal interest. But we need to know that any woman presenting to your hospital will get the same kind of information. And that's why the new framework comes with a structured information leaflet with the infographic for parents, which should never be used as a standalone tool, but can be really useful to standardise the information that parents receive. And so if some of your colleagues are asking about the new framework, point them towards the resources in the document for the communication, structuring the consultation, and working as a perinatal team to have those conversations. Once we've categorised the risk for that pregnancy, which really must be done as a perinatal discussion, then it guides us as to whether actually in this situation we should be recommending active survival focused management, and that is active obstetric management and newborn management. I think really gone are the days where we would be requesting a neonatal person to attend a delivery to see if active care would be provided. If we're going to provide active preterm perinatal care, it has to begin before that baby's born, getting place of birth right, getting steroids right, getting magnesium sulfate in. And if we're going to offer comfort focused management, then that actually probably doesn't necessitate transfer. We should be able to provide good palliative obstetric and newborn management within our LNU and SCU settings. But it's in the middle zone where actually this grey area can be very, very difficult. And that's when seeking parental views and going on the decision-making journey alongside the parents will be really key. So that's just a quick summary of the framework and how I think it's so relevant to LNU and SCU teams, and some of the resources that within it might be useful. So preterm ladies arriving to your LNU and SCU units, how might we change their outcomes, and why might we need to think about that? And really, that's because being born early is one of the leading causes of death and disability in children. But our ability to alter that lies in the perinatal period largely. That's where the big evidence for change lies. And that means that the onus is on every single one of us as perinatal professionals to share in the responsibility of trying to help the baby achieve these outcomes. We need to take the baby from an in utero environment through a period of delivery and stabilisation and try to get the interventions in to help them achieve the best motor outcomes so that they can run around in a field when they're older, the best cognitive and speech and language outcomes so that they can run around with friends in a field. And it can feel like that goal is quite distant. But I think if we measure our outcomes and feed back to our perinatal colleagues how babies are doing, it really motivates us to keep going. So where does this sit within the national context? I'll come to the NHS long-term plan in a minute, but many of you will be aware that for several years, NNAP have been collecting data on some of the key interventions, and I'll talk about the latest NNAP report in a moment. The National Maternity and Neonatal Safety Improvement Programme have optimisation and stabilisation of the preterm infant as one of their key drivers. And that's really going to come into play in the next year or so, with people being asked to really focus their quality improvement work as a perinatal team. And that's where BAPAM has come in. It's brought the issues highlighted in the NNAP data together with what the Maternity and Neonatal Safety Improvement Programme want to do, and that's helped us to develop this series of perinatal optimisation toolkits. And it's all being driven by a very ambitious goal set by the NHS long-term plan to reduce newborn brain injury and death by 25%. So we've already passed the 2020 timescales, and there's still so much work to do. And the majority of mortality and morbidity, especially with brain injury, is with our preterm population. So let's look at the latest NNAP report. And I think it makes for quite stark reading, because clearly there is huge variation nationally. There's 14 networks across the UK, and the mortality, if you're a baby born in each of those networks, varies from 4.95% to 9%. So it doubles in some region, and it's not explained by social demographic case mix. And other outcomes, chronic lung disease, necrotizing enterocolitis, vary really strikingly. So how can we make sure that no matter where you're born in the UK, you get the very best perinatal care? So NNAP has really made some clear recommendations that we need to improve care processes, thermoregulation, hence the BAPM normothermia toolkit, which I've found so useful. Improving magnesium sulfate, the National Precept Project's done a fantastic job with that. But there's more work to do, most notably around breast milk feeding, which Ros will come to, and around optimal cord management, which George will talk about. And how does this all fit together? This is BAPM's perinatal optimisation care pathway. You'll see that counselling of parents and shared decision making sits alongside the whole pathway, but it's about predicting preterm birth, identifying the risk so that we can optimise them with place of birth, appropriately timed steroids, magnesium, antibiotics for the mother in certain circumstances, optimal cord management, normothermia and maternal breast milk. So I think that this is very key for us as LNU and SCU teams, is place of birth. We all know that despite our best efforts, women at risk of preterm delivery below 27 weeks or below 28 weeks for multiple births will still present to LNU or SCU units. And I confess to thinking, well, maybe it's because of the case mix that appears in the units that we can't, often they're more emergency, unplanned deliveries, or is it the transfer afterwards? But either way that you look at this data, it's absolutely incontrovertible that babies born outside of a tertiary unit with a co-located NICU do not do as well. They have an increased rate of mortality and over twice the rate of severe brain injury. And it's quite compelling to think that the number needed to treat is just 8, or the number needed to transfer. If we could transfer 8 women to deliver 8 babies in the right setting, we will prevent 1 case of severe brain injury. But this one is really hard to get right. In my own LNU, we have not been doing well at this. And so we did a very deep dive into 5 years of data. We looked at the referral pathway, the triaging of women, decision making, and then the network pathways of accepting these women and how you transfer them. It is not easy to get right. But there's some really good hints and tips in the antenatal optimisation toolkit on the BAPM website, because you can see this real big variability. There's my own region, the Southwest, not doing very well, and my own unit has not helped that at all. But you can see that in other regions, particularly in the Northwest and the North region, Thames Valley and Wessex, are doing much better at this. And so trying to interrogate regions that are doing particularly well at this is really important. I would probably exclude Scotland from there because they mainly have NICUs, so it's hard for a baby to be born outside of a NICU setting. So what about steroids? We know that steroids are really beneficial for both survival and reduction in IVH and better long-term outcomes. But whilst the NNAP has been looking at many years for babies who receive some steroids, how do we make sure that they are timed properly? And that's really key. So all I could strongly recommend is working with your obstetricians in your units. Go and find your lead labour ward obstetrician, the person who's really keen on quality improvement, and work together. How can we improve this? Do we have a problem with timing of steroids? Because we know that if we're giving too many steroids to women who won't deliver, that those babies who then deliver at term don't do as well either. So how do we get this really fine line correct? And you can see there's huge differences there as well with administration of steroids nationally. So magnesium, the PRESET project, of which Periprem is the follow-on project from it, has been fantastic in increasing the uptake of intrapartum magnesium. And it's so important to remember this relatively simple intervention. Again, if we could give that to 37 mothers in preterm labour, we'll prevent one of their babies having cerebral palsy, and it's not an expensive intervention. So I've mentioned Periprem a couple of times. It's what we're doing in the southwest of England, and this is just one example of the kind of passport that can be very useful to track the interventions, collect data, and it's referenced in the BAPM toolkits as in lots of different ways, some of our parent information leaflets. But just thinking about ways you might be able to implement something similar in your own unit or your own network, about how we make sure that every single baby and woman presenting to our LNU or SCU units gets every single element of this. And they're not all easy to do. They're not all new either, but putting them all together in the journey can be challenging. We've also done a parent passport or a baby passport, which really empowers the parents to understand these interventions, particularly if they're being moved to the place of birth, why that is, and to really empower them to engage. So finally, if you haven't yet, please go and have a look at the optimisation toolkits on the BAPM website. They're a really great source of useful information and resources, and yeah, they're all free to download, so please do go and have a look at them. And as I said, the key to making this change is to work as a perinatal team, to stop being a neonatal team or an obstetric team and come together to fix these problems. And that's only really highlighted with maternal breast milk and optimal cord management. Those two interventions you cannot do in isolation. And so now I will hand over to George to talk about optimal cord management.
I'm a neonatal nurse consultant, and I work on a level 1 ANNP led neonatal unit in Northumbria, so we've got the claim to fame, if you like, of being England's most northerly neonatal unit. We support a delivery centre that delivers about 3,500 women a year, so we're quite a big maternity service that is actually supported by a level 1 SCU. And we admit about 400 babies to special care or neonatal transitional care each year. In terms of levels of prematurity that we care for, we aim to care for all of our babies born in trust at greater than 30 weeks gestation. However, about 3 to 9 babies per year, depending on what kind of year we're putting in, are born at less than 30 weeks on our site annually. This is quite a small number of babies considering the size of the maternity unit, but that's because we've got a very robust mechanism for intrauterine transfer within our local operational delivery network. Like Sarah said, a lot of our very preterm babies that are born on a SCU site differ very much from a similar baby born at gestation within a NICU. Our babies, last year, we had 9 babies born at less than 30 weeks. 8 of them delivered or had to be delivered by cesarean section within an hour of hitting the delivery suite. So transfer to another centre would have been impossible. But also as well, when people get admitted requiring urgent delivery or in advanced labour, we've got an even harder job to push all of the optimisation levels to get them into the time available. And we're particularly proud that we can very rapidly deliver magnesium sulfate and intrapartum antibiotics. Have the next slide, please. I apologise for the repetition, but actually the aim of my little session here is just to talk about the fact that we are wanting to look at providing all preterm babies of less than 34 weeks gestation a period of optimal cord management, which is defined by just holding off with the clamps and the scissors for up to at least 60 seconds after delivery. Within Northumbria, we've had universal optimal cord management for all infants of all gestations, regardless of place of delivery in trust or mode of delivery, since 2009. So hence this is why we've been involved and we've been happy to support the development of the toolkit. Could I have the next slide, please? Points that you've got to remember is with looking at introducing the improvement programme, it does pertain to less than 34-week babies, but you may decide that you want to increase the reduction of early clamping rates for the total of your newborn population. If you want to look at optimal cord management, you might want to start from the very beginning and do what we did and look towards improving optimal cord management for all gestational groups. However, we do appreciate that the evidence and the supporting data that we've got largely pertains to studies and to cohort studies and randomized controlled trials dealing with preterm deliveries. So hence that's why this toolkit, which has demonstrated a greater benefit of optimal cord management for the preterm babies, is promoting babies of less than 34 weeks. A good idea really, if you think about it, is where you are sitting now today, can you actually provide any insight, or do you have the figures to hand to determine what level of babies currently within your unit receive optimal cord management as a primary benchmark? If you are looking to implement parts of the optimal cord management toolkit today, you would probably do well to pull back before you start introducing anything such as management of labour ward or looking at how to actually provide optimal cord management, and just actually start with looking at where things currently stand on your unit. To look at optimal cord management in preterm babies within a local neonatal unit or a special care unit isn't too onerous, and that's because the numbers are quite small. And some of them will be born below the gestational threshold for your unit, but even the babies that can be provided or planned care to be delivered in your unit, which for us would be the babies from 30 weeks to 33 plus 6 days, is part of the toolkit. The numbers of those babies is quite small, so it isn't a huge job to collect data and to ensure that data is complete. The next slide, please. If I was going to share anything from our experience of introducing optimal cord management, I would share these three things that we learned, because we kind of did it as we went along. And some of the changes that we did took longer because they were poorly planned and they were badly negotiated. I can put my hand up to that. But first thing that you really need to do is develop a process and just plan how you are going to go about it. And then you need to actually test the implementation plan that you are going to put in place. And then you need to see if your actions have actually made a difference to the rates. And that's why it's important to benchmark your current optimal cord management rates, because you can't demonstrate an improvement until you've actually got the figures to hand. Next slide, please. When you're developing a process, the best thing to do, I think, with any part of the perinatal optimization toolkit is to engage everyone around that's got a stakeholder, everyone around who's a stakeholder in the process or in the intervention that you want to introduce. I cannot stress enough engagement. I'm the neonatal nurse consultant on our unit, not because I'm the best ANNP, because I'm not by far. I work with some excellent clinicians, some very, very capable people who completely blow me out of the water clinically. But the reason why I've got this job is because I'm the one that can probably be the best person currently to link in with other parts of our organisation and our network to actually promote practice and to support change within our unit. You do need lots of champions to advocate for optimal cord management. And this needs to be whoever locally can make things happen. It doesn't necessarily have to be, the more senior paediatrician within your district general hospital or going to have a word with the head of midwifery and the labour ward lead obstetrician. It needs to be the people that actually hold the clamps and the scissors actually on the delivery site. They're the people that need to be involved, and they're the ones that need to be won over because they've got, you've got to get the message across to them. So within our unit, we did involve our obstetricians, and we involved our midwives and paediatricians and consultant paediatricians and the neonatal nurse practitioners and our neonatal nurses. The one thing we needed to do, and we didn't at the time because it was a complete oversight, was we didn't involve the theatre teams enough. A lot of these very preterm babies, as everyone knows, can be delivered in our obstetric theatres, not born by elective, semi-elective or emergency caesarean section. And if you forget about your theatre team, you know, it's really hard for you to introduce suddenly at a bedside when everyone's scrubbed for them to actually leave a baby with the cords clamped and unclamped, and to support the baby at the operating table. If they're not prepared for that and if they're not comfortable with that. If you currently don't scrub for caesarean section, and I appreciate in some areas some babies are actually delivered and the delivery operator places the baby into a cot covered with a sterile drape, and then the baby's wheeled to the resuscitator. If you currently do that, it's quite difficult to implement optimal cord management because it can only go ahead if the baby's been appropriately managed within the first few minutes of life, in terms of management of temperature, management of optimisation of airway, and also to get a knowledgeable and detailed assessment of what's going on with that baby in the first minute. We cannot reasonably leave this to theatre nurses who are trying to dry babies off for you or wrap babies in plastic, and we cannot leave it to the obstetricians either because they've got their job to do at the time. And some of these deliveries are very high risk. If women are being delivered because they're bleeding and things like that, you know, the obstetricians with the best will in the world want to support you to hand you a baby in good condition, but they've got their job to do, which isn't the immediate assessment and management of a newborn baby. This sometimes takes some negotiation with theatre and with the maternity services because I appreciate there's a cost implication to extra clinicians scrubbing at an operating table, but it can be actually resolved, any concerns that anyone has, by appropriate negotiation and having to have a good conversation. Within the national and local maternity and neonatal agenda, safety is obviously very much in everybody's eyesight, and there is the development of the neonatal and maternity safety champions within each NHS trusts. These kind of people, for all that they are not the people that can actually be directly involved with the provision of optimal cord management, are high profile, and they can be very useful in keeping optimal cord management or any aspect of the BAPM toolkits on the agenda. They can keep things like this on the table. You know, they've got the power, the appetite, the interest to actually think, well, you've talked to me about normothermia this week, I'm going to put it on the agenda with our governance meeting in 6 months' time, and I want something, you know, and I want an update, and I want to know what the unit's doing to implement things. And they can be very supportive to get things done and to help the senior midwives and obstetricians get an appetite for optimal cord management. Guidance is good, and everybody needs to be able to work with us within some standard operational guidelines. It would be very useful for neonatal units, especially the level 1, level 2 and level 3 units, to push for a regional network guideline. And we're currently working on that within the northeastern Cumbria neonatal network. But if you're not going to get one and there isn't an appetite for a guideline on optimal cord management locally, you could always create your own and run with your own. The toolkit is a very good resource for the development of your guideline. The evidence is already there. If you need to reference things, all of the work's largely done for you. In terms of the evidence, make it available within your maternity units. Within the BAPM toolkits, there's some very short, punchy infographics that are quite emotive and put the message across very, very clearly. Take-home messages which can actually win hearts and minds within your maternity and neonatal team. Could I have the next slide, please, Sarah? Because of this, like every change, people do have a personal investment in what they've done. And if you're as old as me and you've delivered babies for 30+ years, optimal cord management is a behaviour change, and it's an attitude change, and you have to revisit the knowledge that you trained with and incorporated in your practice and learned from the very start of your career. When I was a student midwife, if I had to deliver a preterm baby, I think you were kind of measured the degree of success of whether the paediatricians or the nurse practitioners appreciated what you were doing was by how quickly you could put those 2 clamps on and get that cord cut so you could hand them the baby so they could save the baby's life. Whether the baby needed its life saving or not, it got it, because that's what we did then. And a lot of us have come from that background or a variation of that background, and also as well, like Sarah stressed before, very preterm babies are an infrequent event. In a unit the size of my unit, there's 100 midwives work within the department, and if there's only 9 very preterm babies being born a year, that's a lot of experience divided by very little experience divided by a lot of people. So you need to support people dealing with very, very infrequent emergencies. You need to actually appeal to what is known about optimal cord management and using the infographics, like I've said. And the statements on this slide here are very emotive, and they can be put. This slide's been a variation of the slide has been printed off and laminated in the changing rooms within our operating theatres, just to get everybody used to the fact that actually, it's not an option, it's not something nice to do. It's an intervention that doesn't cost anything, but actually makes a huge difference to the babies that we look after based on the data that's available. You will have some opposition, and people always revisit opposition to cord management because they talk about babies that get jaundiced. Everybody's met the one baby that was desperately polycythemic, and they've kind of put that down to a delay in cord clamping at some point in their career. Midwives will worry about things like the incidence of postpartum hemorrhage and the risk of maternal retained placenta. But the evidence is there. The evidence is available to say that optimal cord management does not really influence these things to any great degree. Could I have the next slide, please, Sarah? Thank you. Brilliant. Moving on from appealing to the evidence, promoting your change, you do need to actually test your process, and you need to involve everyone in an equipment and an environment review. You need to physically look in every room that a baby could possibly be born in within your unit, and it's places like pregnancy assessment unit, antenatal wards, not just the delivery suite and the obstetric theatres. Think about, if a baby was born on this bed today, how could we do optimal cord management? What do we need to have handy on the pregnancy assessment unit to do this safely? What do we need to do differently in theatre to make this happen? And because of that, you need to involve everybody who works in these rooms, and you may have to test things with using scenarios, because they will engage and they'll train people, and it'll get people used to talking about optimal cord management, and it'll test your process. A lot of it's about awareness, and this is not just awareness with the staff, it's talking to parents, it's including it in antenatal conversations and in any education or any written information that you give women of high risk preterm delivery, and rediscuss optimal cord management at our preterm birth clinics that are provided by the specialist midwives. It's to talk about the role allocation, what is everybody's part in providing optimal cord management. And I could revisit what I've just said before about things like within an operating theatre, whose role is it to actually make sure this baby's temperature stays okay, make sure this baby's airways open, make sure this baby's being assessed properly, and how do we communicate when we are going to stop optimal cord management. There is always some babies that for optimal cord management will not be appropriate, and I do believe that that's not my decision, and it's not it's the delivery operator's decision. But if they've got a very strong rationale, for example, cords that's very short, or very, very short cords, I've only ever seen 1 or 2, I'll be honest. But if they're delivering a woman with an antepartum hemorrhage, and they can obviously see placental separation and things, they might make the decision to clamp and cut the cord, but they need to communicate that to you, and they need to discuss why they are doing that. In terms of testing the scenarios, you can include this in your local obstetric and neonatal mandatory training for skills drills, and it works very well. And with that as well, if you do provide some of the infographics from the optimal cord management posters pertaining to things like place of birth, pertaining to things like steroids, magnesium sulfate, and if you try and include that as part, if you like, of neonatal life support, it'll engage everyone in thinking about the baby. You know, the baby's not just a problem the second it hits the resuscitator. The baby needs to be managed before that and can be optimised in lots of ways. Within our local prompt training, I often say that the people that can make the best difference to a neonate is the things that can make the best difference to a neonate are totally beyond my control. On a level 1 SCU unit, we can all have the Arnie course, you can have fantastic nurse practitioners on, you can have all singing and dancing ventilators, but the big things that make a difference to these babies is it would be nice if they weren't born in our unit at all, if the woman was transferred out, and it would be brilliant if the baby had the full optimisation package if that wasn't possible. Those are the things that make the difference, not a lot of things that we actually do. We have the next slide, please, Sarah. Thank you. A minute is a long time if you haven't seen a baby born at less than 34 weeks or 32 weeks or 30 weeks even in the last 2 years. You know, and that can be the experience of a lot of midwives that work within a level 1 or a level 2 neonatal units delivery suite. So, you know, what we've actually done is we've actually tried to say, you know, use the minute well. You know, people panic and people want to clamp and cut cords when they think nothing's happening and nothing's being done for the baby. But this minute cannot be this minute can be used very well and can be filled very easily without actually delaying any care. I'll be honest with you, when we first introduced optimal cord management within our unit a long time ago now, there was instances where babies were kind of born and staff used to like almost stand around and look at the baby and, you know, wait for something magic to happen because the baby was getting some blood from the placenta. But we've moved on from that, and so we do talk about things like, you know, at delivery you negotiate with the woman and the caregivers what's going to happen. You think about a safe surface for the baby where the baby's going to be delivered onto. You don't need separate resuscitation platforms. At Northumbria we happen to have the livestock platforms and we don't have any resuscitators in any of our rooms. We just use them for transfer to special care baby unit. But that's pertaining to us, and it's resuscitation with an intact cord is beyond the scope of this guideline. It's not what is initially being asked of you in terms of benchmarking and changing your clinical behaviour. You know, we manage normothermia as per gestation. Optimal cord management can do this. Just because the cord's clamped and uncut doesn't mean the baby cannot go into a neo wrap. You know, you might have to be a bit more imaginative and have the cord coming out of the bottom of the neo wrap. Other times I've seen a baby wrapped up and the cords actually come out alongside the baby's head. You know, whatever people feel comfortable with, as long as they're managing the baby's temperature properly and preventing heat loss. Area positioning, very easily done, can be done on an operating table whilst this magic minute's happening. And you know, you've got to try and remind people that these baby preterm deliveries, yeah, you know, they are dramatic if you don't see a lot of them, but most preterm babies are born with some respiratory effort and not going to need a lot of things doing at the within the very first minute. And then following on from that, you can actually make a detailed assessment of the baby's, you know, colour, tone, breathe and heart rate per NLS guideline. I cannot stress enough, concentration on what can be done within this first minute, and if it's done well, helps increase the confidence to provide optimal cord management. And scenarios work very well with this if you try to win people over, because if you let people do what they conventionally would do, clamp, cut, hit the baby onto the resuscitator surface, they then spend another minute wrapping the baby up properly and listening to heart rates and opening airways, and you think, well, you could have done that, whereas the baby was still getting some blood from the placenta. You know, it's very good to demonstrate that to people. It works very well if you actually do it both. If you do it both ways and show how the time spent more or less doing the same thing with and without cord management, optimal cord management. Could I have the next slide? Thanks. Yeah. In terms of looking at what you benchmarked at the very beginning before you implemented any changes, you really need to look at how you're going to measure your outcome. Like I've said before, within a local neonatal unit or SCU, the numbers won't be high. Within our site, it's about 30 babies a year. I can only imagine within a level with a local neonatal unit, it might be twice or almost 3 times that, but it's still not going to be a huge amount of babies considering the amount of babies that are born in your trust each year. Record keeping is quite important. We make it a requirement in our notes, and if your document at the moment doesn't pertain to optimal cord management for preterm babies, you can navigate around that by making a sticker that can easily be put in the notes just to capture the details, just to help some poor soul that's coming along trying to collect the data and the evidence to see if you're actually implementing the recommendations of the toolkit. We encourage the neonatal nursing team to detail in the resuscitation notes and in the admission record whether optimal cord management occurred and for how long. And BadgerNet, which will actually collect some of the data, especially for the babies less than 34 weeks, the BadgerNet data entry, we very much push for this to be completed as much as possible. Within BadgerNet, when it comes to optimal cord management, it says yes, no, unknown. We very much pushed from the start when we wanted to measure this, when it was included on BadgerNet, not to have anyone clicking unknown, because that's data that's lost, it's incomplete data, and it helps no one. At some point it would be very easy to find out whether or not this baby benefited from optimal cord management. Within the toolkit, there is an exception report, which is a small record where you can actually reflect on and collect the data of any baby less than 34 weeks that did not have that 60 seconds of optimal cord management. This is a very useful way of maintaining momentum for change, because it's a good way of managing outlier clinicians. And data collection, like I say, people need to be identified to do this, but it should not be too laborious because the numbers of these babies in our units are quite small. We have the next slide. This was just one of the ways that we actually documented it very easily on. It was just a matter of, whether or not the baby had delayed cord clamping, as we called it at the time. And, we used to write on there how many minutes the baby had delayed cord clamping, so it was very easy to pick up within the baby notes. Next slide, please. You've got to maintain momentum if you do implement any changes, and how we've done this in the past is by creating a red, amber, green dashboard. It's demonstrating compliance, and this can be also done with the normothermia care package. Compare your data with the last year's statistics, which can be obtained very easily from anyone that can navigate BadgerNet. And keep in the spotlight the reporting any changes in optimal cord management rates to any user groups, any governance groups, any operational board groups within your maternity departments. It may get added to your maternity dashboard, so it can be reported and monitored. Just keep it within the public domain, if you like, within your delivery department. And next slide, please. Basically, I've just put this slide on just to let everyone know that that's my work email, and if I can help anyone at all that works in a level 1 or level 2 unit to support change or to discuss any particular problem you've got, if the toolkit cannot help you, which I think will help cover most concerns and questions that people have, please get in touch with me. Thank you. Thanks very much, Sarah.
Thanks, George. That was fantastic. I'm going to hand over to Rod now.
Thanks, Sarah. Just share my screen with you. Okay. Can everyone see the screen I've shared, hopefully?
Yeah, all
Lovely.
good, Rod. Thank you.
Thank you. So good afternoon, everyone. My name is Ros Freestone and I am the neonatal infant feeding specialist nurse in Swindon at the Great Western Hospital. And I want to talk to you this afternoon about how you can optimise early maternal breast milk in either your local neonatal unit or your special care unit. So why is it really important that we try to get these babies to receive their own mother's breast milk early on? So the evidence tells us that maternal breast milk will reduce the baby's chance of developing chronic lung disease. It will reduce their risk of developing retinopathy. It has protective factors that will promote their gut health. It will reduce their likelihood of succumbing to a serious infection or necrotizing enterocolitis. But most importantly, it can reduce their risk of death. For these babies, receiving their mother's own breast milk can literally save their lives. And what's so important for parents, well, us to know as professionals, but also parents to know, is that no one else can replicate the protection that the breast milk can provide for this baby. There's not a procedure that we can perform or a medicine we can give that will offer the baby this level of protection. Maternal breast milk is completely personalised and completely precision medicine for this baby through this amazing bronchomammary or entomammary pathway. And I think for parents to receive this information at a time that is hugely stressful to them, when they feel like there's a complete loss of control, can be really empowering for them to give them this one thing that only they can do for their babies. And in Swindon, we recognised that we had a problem in terms of the amount of time it was taking for our babies to receive their mum's breast milk. And so we embarked on a quality improvement project. And as you heard George just say, collecting your data before you even start to try and improve anything is really important. And so on this graph, each of these purple diamonds represents a baby born in our unit at less than 32 weeks. And going into 2014, it was sometimes taking us beyond 3 days for our babies to receive their own breast milk. And you can see that now, with the implementation of our quality improvement project, there are a lot of babies who are receiving their mother's own breast milk close to the time of their birth or soon after. And we're really proud that within our own network, we consistently have the best breast milk data, thanks to our quality improvement project. So I want to share with you some of the ways in which we've been able to be so successful. And I thought one of the best ways to do this would be to share a case study with you. And what's really nice about this case study is it's also a collaboration between a special care unit and a local neonatal unit, so really appropriate for today's learning. So we recently cared for some twins who were actually admitted to their special care unit at just below 30 weeks. So they fell outside of the criteria for being appropriate to deliver at that unit. And so they started to arrange transfer to Swindon, our local neonatal unit. But while they were still in the special care baby unit, a Preterm passport was commenced, and you saw from Sarah's slides what that Preterm passport might look like, that bundle of interventions to optimise these babies' outcomes. And one of those interventions is related to maternal breast milk. And so the mum received some really good information about the benefits of breast milk to her babies. And at the bottom in purple there, I've just highlighted the perinatal core elements that highlighted by the BAPM toolkit for maternal breast milk. So element 1 is relating to parents as equal partners in their baby's care. And by providing the parents with this information, we really empower them to take control of this area. And this is a copy of the leaflet that the parents will have received about the benefits of breast milk for their babies. And what I really like about this leaflet is it doesn't actually require the parents to make any kind of decision about their intention for feeding at that point. It just provides them with evidence-based information about the benefits for their babies and tells them how they can start to to express their breast milk and start that journey. And our own data showed that as we increased the amount of parents receiving that antenatal information, the time to the babies receiving the breast milk reduced. So these babies, this lady was then transferred to our local neonatal unit, where she had some antenatal counselling from our neonatal consultant, again emphasising the importance and the benefits of breast milk to those babies. The delivery suite staff then supported this mum to do some hand expressing immediately before her caesarean section, so that some colostrum was harvested ready to give to her babies once they were born. And we gave her a liquid gold pack, which is an excellent resource. And in our liquid gold packs in Swindon, there's some written information for the parents. There's also the syringes to be able to harvest the express colostrum, and also some cotton bonding squares for the mum and the baby. And having all those resources made up into a pack that's easily accessible and to hand is really important. And you can see that the evidence supports that early expressing. Those mums that are able to express either antenatally or within an hour of their babies being born are able to produce 3 times more milk by 3 weeks old compared to those mums that wait for longer. So when these babies were delivered, both parents were able to have a delivery room cuddle with their babies. And the babies received their first maternal breast milk as buccal colostrum at just 30 minutes of age. And again, you can see that these are supported by the core elements from the BAPM toolkit, which aims for the babies to have their first breast milk within 6 hours of their birth. And the early and regular parental physical contact is really important. So shortly after the babies were born, I went to have a conversation with that mum, and we made a plan about how I could support her with combining hand and pump expressing right from birth. And also we talked about the benefits of prolonged skin to skin. And again, the evidence shows us that being able to combine hand and pump expressing right from birth will yield 5 times more milk by the 7th day versus hand expressing alone. And that utilising double pumping from birth will increase the milk volume by 50% versus sequential pumping. And again, the BAPM toolkit supports that early initiation of expressing, aiming for a target of within 2 hours. So when this mum was well enough to be discharged from maternity services, she was able to room in on the neonatal unit. And we would have welcomed Dad as well, but unfortunately he was self-isolating at this point. And we made sure that at every stage of this mum's journey and each of the areas she was cared for, she had access to a breast pump. And I appreciate that we're very fortunate in Swindon to have a provision of parental accommodation and access to lots of breast pumps, and that might not be the case in your unit, but that doesn't mean that this isn't something that you can offer to parents. Sometimes it just requires thinking outside the box a little bit and not immediately saying, no, this can't be done, but thinking, how can we make this happen? So if you haven't got rooms dedicated to parental accommodation, could you invest in some camp beds for parents to be next to the cot side? Could you invest in some reclining chairs where parents can sleep next to their babies? And if you don't feel you've got enough breast pumps, how can you make that happen? Is it possible to use some charitable funds or to find some willing donors? It's all about thinking creatively. So on the second day after these babies were born, I completed the UNICEF Expressing Assessment tool with Mum. And this is a tool that's readily available on the UNICEF Baby Friendly website under their resources. And it's a tool that's incredibly useful to support mums in the early day of their expressing. And at that point, I identified a couple of things that could be improved for this mum. So she was only expressing about 4 or 5 times. So we discussed increasing the frequency of her expressing. And I also identified that the breast shield she was using wasn't the correct size. So we changed that to one that was more appropriate. And again, the evidence supports that if mums express 8 to 10 times in 24 hours, the volume of milk they will achieve is increased by 50% compared to those mums that are expressing less than 7 times per day. So by day 5, both of these babies were fully fed on all maternal breast milk and so had their central lines removed. I completed that expressing assessment with that mum 4 times in the first 2 weeks to really give her the maximum support in being successful in expressing her breast milk. And at just over 32 weeks, those babies were able to be transferred back to their local special care unit for ongoing care. And we had some lovely discussion between the 2 units before that transfer to really give the parents confidence and prepare them for the journey back to their local unit. And I've put a little gold rosette there because I really think this was a really great success story for these babies and for this family. And so I just want to share with you some of the things that have been really key to how we've managed to be so successful with the rates of our maternal breast milk and the early administration of that breast milk. And as George and Sarah have both said, it's really very much about developing an excellent perinatal team culture and making sure that there's excellent communication. And particularly with breast milk, it's really important to make sure that it's a shared responsibility. It's not just down to the midwives who work on delivery suite and not just down to the neonatal nurse who's looking after that baby. It really must be a shared responsibility. By giving parents antenatal or early education about the importance of breast milk, you really empower them to be owners of the importance of breast milk, take ownership of that and empower them. Having resources like liquid gold packs or something similar that's ready to hand is really important. And making sure you identify those people that are really passionate about this area, making them unit champions, and making sure that that enthusiasm is spread and education is spread to make sure your staff are skilled with the teaching mums hand expressing and also how to use the breast pumps properly. Making sure that there's enough access to breast pumps for mums, making sure that they've got access to that equipment and that support. Parental accommodation, I think, allowing parents and promoting parents to be with their babies if that's their wish and being creative about how you can facilitate that. As we've talked a lot about, recording and tracking your data can be enormously useful, not only to show you areas where you need to possibly improve, but also so you can share your successes. And in terms of resources, just look what's available out there. Obviously, we've got the BAPM toolkit, but there's lots of lovely work going on throughout the country. So share and borrow their resources with other teams, because that's really the way forward to make progress, is by sharing excellent practice so that that can be spread. And I'm really looking forward to hearing in our discussion some of your tips and ideas so that I can also learn from this as well. So thank you ever so much, everyone, for listening. Just unshare my screen.
Thank you so much, Ros and George, to both of you. So we've got a few minutes left now, and I was making a few sort of notes through that chat and just thinking about how much it matters to come together as a perinatal team in our SCU and LNU units to empower the champions to implement this and to make sure that even if we have babies born with us, that we implement this part of the journey before they get transferred out. So to be able to hand over to the transport team that this baby has had as much of the optimisation journey as it can. It's had its first lot of breast milk in and have some breast milk ready to go with the transport team. And I think it really is about tracking your data, winning hearts and minds and using the evidence. So we're just going to take a few questions. So thank you to Rosgar from Merseyside. I don't know if you want to unmute and ask a question. Ros, we've got a comment about having a checklist for perinatal management and advocating for early breast milk. But a parent representative thought that that push was excessive. So, Ros, I know, thank you, and I'm sure that Ros Freestone will have some thoughts on that too. We have been over this issue about whether we are pushing too hard on parents to express breast milk. And we had 4 parent reps as part of the BAPM maternal breast milk toolkit recruited through Bliss. And we put that topic to them and we said, are we putting too much pressure on you? And every single one of them said, actually, no, it was the most empowering thing that I could do for my baby at a time when all the other power for that journey was removed from me. It was the thing that I could do. And I think it's about how we approach that topic. If we talk to the parents about how much of a difference it makes, how unique it is, how bespoke it is, then actually Ros and I would find it very rare for a mother to not want to provide breast milk. And especially when we talk about provision of breast milk rather than necessarily breastfeeding for families that may not have made that choice yet. I don't know whether Ros or George, you had any other comments?
Yeah, I completely agree with you, Sarah. I think it's I think if we don't have those discussions with those parents, we're actually doing them a disservice. I think they've got a right to know that information. And as you said, you know, we're empowering these parents with that knowledge and not pushing them into a feeding decision, just providing them with evidence-based information about something that they can do in a time where there's not an awful lot else they can do that can make an enormous difference to their baby.
Can I comment, if that's okay?
Yes, please do.
Yeah, first of all, thank you for this meeting. It's been very informative. In the context of breast milk, I have not had a personal encounter with a parent who thought that it shouldn't occur. I agree with you, is one thing you can do for your own baby that most people cannot do. But this person was actually at a national platform as a parent representative, and that was the person's view. So we have to acknowledge that. But I agree with you, what we're saying is providing breast milk for a sick infant. And the moms I've always encountered have said they're happy to do that. They might not necessarily want to breastfeed, but they definitely provide the milk for the sick baby at that point in time. So I think it's something that ought to be looked at, especially if you have a national representative saying such a thing. And the other thing I was going to say was, in the context of the Periprem, I was quite surprised but happy to see that Periprem performance that's been put together, because we've done that locally as well. But what we've done was like a checklist, because we thought really there isn't much time, we've got to do everything in tandem. So we put all that as a checklist, and we thought if we are failing on an aspect, then we have to do a deep dive to find out what exactly is happening. So I was very happy to see the Periprem passport. I agree with you. I think we've got to do these things together as a team, and we've got a big team together that's working. Part of it started with the Mat Newsib, but we've got a team of, it ranges from midwives, obstetricians, and pediatricians, but we've actually got some trainees who are very keen, which was very nice to see as well. So yeah, thank you.
Oh, thanks. No, I completely agree that having it down as a sort of a passport is just so useful. So just a couple of other comments, just reading from the chat here, is about the issue of approaching transfer out of a potential preterm and then being told, but they're not doing anything, and a reluctance to transfer. I sympathise so greatly with you, Rachel. I think we all do who are in SCU and LNU units. And there's often that conflict between the obstetric team and the neonatal team. I think that to some degree you can improve that by improving the accuracy of diagnosis of risk of preterm delivery. And I've certainly been quite impressed in the Southwest with the changes that we've introduced, because we've got network-wide introduction of fetal fibronectin with the QUIP app, which gives you a really good assessment of risk of preterm delivery, and that allows everyone to be on the same page rather than it being a subjective decision. And I can see people's reluctance either way. It's very time consuming, it's very imposing on staff to have to move women. It's awful for women who are moved away from their family, and if we move a load of women that don't need to be transferred, we're taking up tertiary maternity bed capacity. So I think getting the diagnosis of preterm labour right is really, really important. And FFN and the QUIP app has been really useful and is one of the suggested strategies within the AO toolkit as well. I'm just going to move down slightly. Ros, I don't know whether you want to answer this about pumps after birth. So people were saying that they used to use pumps straight after birth, but now they've been stopped doing that until mums are getting higher volumes because they're worried about losing colostrum in the pump equipment.
Yeah, have to say I'm converted recently to pumping and hand expressing. I always used to absolutely advocate just hand expressing because that was my concern, that, you know, mums would be pumping but we'd lose the milk in the equipment. But actually the evidence is just, you know, I have to go with the evidence, and actually it shows that if you combine both hand and pump expressing right from birth, by day 7 you're getting 5 times more milk than hand expressing alone. So you really can't argue with that. And I would say the way that I've approached it is it's the combination that's important. So I would always advocate that a mum hand expressed initially and then use the very sophisticated breast pumps in that initiate mode for the stimulation, and then went back to hand expressing afterwards. And that way you will have the benefit of the stimulation to increase the milk volume, but obviously the hand expressing part will still allow you to collect the colostrum, which can then be given to the baby.
Amazing, thank you, Ros. And perhaps a question for George here about improving confidence in practicing intact cord resuscitation. My suggestions would be that on the Preterm website there's a few videos which show different ways of doing this as cesarean section or vaginal delivery. And certainly for us in Swindon, simulating it with the whole team really helped to practice. But what would you say, George, about confidence in practicing optimal cord management?
I think the other thing as well that can work with that is if it makes a little bit of a workforce demand, but if very senior people start coming to the deliveries to help push the change forward. Because I could imagine, I don't work in a medically led unit, but I could imagine if you were a relatively junior doctor and you were much more comfortable at a resuscitator where everything was to hand, if there was somebody else there that was just supporting you, just to say, you know, everything's fine, you know, the baby's okay, you know, and just to give people a little bit of confidence and a little bit of support. And we certainly did that when we introduced universal optimal cord management for all babies within our gestation. For about a year or so, the ANNPs hung around a lot more deliveries just to make sure it was happening and just to support the midwives becoming comfortable with the change.
Thank you so much, George. I can see how that would be so applicable to so many units. Are there any final questions? I just wanted to thank Kate very much for hosting us all. It's been amazing to see 72 people from local neonatal units and special care units across the UK joining this. It's so wonderful to see, and I really hope that you've found this useful. Oh, 105, thanks, Kate. Just to reiterate, we would really love feedback because this has been a pilot session. If you found it useful, do let us know. Let us know what topics you'd like to focus on. I think we were thinking of a second session focusing on term issues, especially things like HIE. And also just a final mention to you all, please, if you're not a BAPA member already, there's so many useful things that come with that, so please do consider joining. And finally, Ros and George, what a privilege to spend my afternoon presenting with you. Thank you so much. It was really lovely, and have a great week, everyone. Thanks so much. Bye-bye.
Thank you.